Okay, let's finish up where we were talking about the various cardiac pathologies that we were covering in class. The next one that we're going to be talking about is cardiac tamponade. Tamponade can be caused by a bunch of different stuff. Whatever we're talking about, everything leads to a buildup of fluid within the pericardium. It's also occasionally called pericardial effusion. This is going to be something that is affecting the production of pericardial fluid or generally the drainage of that pericardial fluid. So if something is affecting how slowly that pericardial fluid is draining away, one big thing is a lot of chemotherapies will end up causing a lot of pericardial effusions that because of the inflammatory blockages of the drainage of the pericardium. Remember that pericardium is that sac that is actually surrounding the heart. We want a little bit of space within the pericardium. We want this fluid there because that allows the heart to squeeze and kind of not be friction rubbing up against the lungs, rubbing against the sternum, that kind of stuff that's around it. The problem comes with cardiac tamponade if there's too much fluid within this sac. So when this occurs, what's actually happening is you actually end up having a buildup of this fluid because of generally a blockage, right? The blockage of the drainage of that pericardial fluid. Tamponade comes from the same root as a tampon, right? To block up or to stop something. So to tamponade something means to stop it. When this fluid is blocked, this is how we have a buildup of this pericardial fluid within this pericardial sac. A tamponade is a problem because this is going to push in on the sides of the walls of the heart, right? The heart has only so much space within this pericardial sac that it's contained within. So when we start to build up a thicker layer of fluid on the outside of it, well, now this becomes a problem because the pericardial fluid is squeezing the heart. So this is going to lower preload. So this is going to be an issue of diastole. So this is an example of a diastolic failure because this is a preload issue. As you squeeze those ventricles, the ventricles don't have as much room inside that ventricular chamber to actually fill with blood. So if this heart squeezes like normal, like it should, it still doesn't actually have that much blood to push out, right? Because it's not been filled that effectively. So we would expect to see in cardiac tamponade patients, now is when you would hit pause, we would expect to see in cardiac tamponade hypertension or hypertension. Well, we would expect to see hypotension, right? We would expect to see hypotension because we have a drop in cardiac output, right? There's less blood leaving the heart in the case of tamponade patients. So we have hypotension, lower blood pressure in the systemic circuit as the indicator of tamponade. Under normal circumstances, we're really talking about a very small layer of fluid around the heart. The regular cardiac fluid is not that significant. But when we're talking about tamponade, we're really talking about either about double, right? If it's occurring rapidly, if this fluid is accumulating over a period of hours, it doesn't take that much more to actually start squeezing the heart. But if we're really talking about fluid that is being acquired over a period of weeks to months, right, this fluid impairs the function, but because we have this pericardial sac actually stretches over time, it takes a lot more fluid. 1.5 liters is 15 times the amount that 100 milliliters is, right? So if this happens really quickly, well, it's going to fill up that pericardial sac. If we slowly accrue this fluid, the pericardial sac has time to stretch a little bit, but there's only so far that it can actually stretch, right? It takes time to do this. This is a pretty characteristic X-ray of a tamponade patient, right? Your heart is supposed to be taking up about this much space, right? So the fact that the heart is so much hyper expanded is a sign that the pericardial sac is so full of extra fluid. Well, what would cause it to happen rapidly and what would cause it to happen slowly? It depends on the particular cause, but both of them are going to end up with jugular vein distension. Why are you going to see JVD in cardiac tamponade patients? Well, you're going to see it because, well, the right side of the heart that is pumping blood to the lungs, if the heart is being squeezed and the right side cardiac output declines, well, it causes this kind of backup, right? It causes a traffic jam in the circulatory system. So it is a clear, easy indicator, right? You're also going to see a backup on the left side of the heart, but that's a little bit more difficult for you to actually see inside clearly in a patient. So we use the jugular vein distension because it's such a clearly identifiable sign of some sort of structural change in the heart. So Beck's triad is this series of three disorders where we have jugular vein distension because of a backup in the right side of the heart, hypotension because the left side of the heart can't actually pump blood back out to the systemic circuit that well, and muffled heart sounds because you're almost speaking, you can almost hear the heart sounds through that layer of fluid, almost like you're talking underwater, right? So the kind of thump whoosh sound that you're hearing as valves open and close and blood is rushing around the heart, that's going to be muffled a little bit because of things covering it up. This is Beck's triad. And I meant to actually pull this open, but I did not pull it up already. Whoops. A lot of videos. One thing that can cause Beck's cardiac tamponade to occur one thing that can cause pericardial tamponade to occur would be an example of something like a traumatic damage on the heart itself. So if you were to have like a car accident and that car accident ends up damaging and causing an internal bleed within that within that pericardial sac, well, now you have that pericardium filling with blood, that blood squeezing the heart. That's what you're seeing in this patient right in front of you, where the heart is having a hard time expanding. So in response, that patient is their heart rate is going up. Here they're cracking the sternum, splitting across the ribs. And when you look at this is going to cause a big bleed, right? They're cutting into that pericardium. Well, where's all this blood coming from? It's coming from this pericardial sac. This is a damage to the heart that's causing a bleed into the sac that it's wrapped around. That's why this pericardium is going to feel tense, and they've kind of cut away the pericardium in this view here, and now the heart is able to expand as effectively as it once was, right? So just examples of how this would work in real life. When we're talking about coronary artery disease, this is something that we've kind of danced around a whole bunch already, right? We've even talked about coronary artery disease in 1820 last year. Any coronary artery disease that we're talking about is going to cause an occlusion of those coronary vessels. Occlusion just means blockage, right? This is by far the most common thing that we see in patients. This is even a few years out of date, so there's probably even more Americans every year that are going to have heart attacks. And about a third of these end up being fatal conditions, right? So that's a pretty common and pretty high mortality condition for us to talk about. So we're going to talk about the idea of atherosclerosis is going to be covered in that video that we recommended at the beginning in our last day of regular lecture. But I wanted to talk very specifically about LDLs and HDLs. LDLs are low-density lipoproteins. HDLs are high-density lipoproteins. The video that I recommended goes in and talks about this very slightly, but I want to go into it a little bit more depth. These are basically molecules that are shepherding around these dietary fats and these cholesterols that we're consuming in our diet, and we need to disperse out to our cells. So LDLs and HDLs are both things that we need to actually have because these these cholesterols and these lipids that we're consuming, they're actually insoluble in water. We can't move them in circulation on our own. So the kind of the rough, very, very rough version of this schematic is HDLs are going to be a storage molecule that sucks up these lipoproteins and then takes them out to the liver itself, right? Wherever it finds them out in circulation, if they're free, if they're being not needed by the body tissue, they're going to be taken to the liver for reprocessing. But the liver can then reprocess them into LDLs, these low density lipoproteins, and they're low because they're mostly fat, right? So the high density is mostly protein, low density mostly fat. LDLs are actually what is taking these fats out to the tissues themselves, and LDLs are the problem because the more LDLs we have, the greater rate at which we can deposit these fats out in areas that we actually don't want them, right? The more LDLs that we have, the more likely we are going to start having a buildup on the walls of our tissues of fats that really aren't supposed to be there, right? That's why HDLs are generally a good cholesterol, right? Good and bad are relative things inside the body. You want LDLs, you just don't want too much of them. And HDLs are good because they're actually going to be coming along and sucking up these excess lipoproteins, preventing these sorts of occlusions from actually getting too bad. Atherosclerosis is an entire conversation, but one of the things that atherosclerosis can lead to is a myocardial infarction, a heart attack, right? When we talk about heart attacks, you've probably heard of people say it was a massive heart attack or it's a small heart attack. Those are real terms because this is not like a yes, no, the heart is broken thing. There's a big range of effects that you could be having depending on the amount of heart tissue that is affected by this blockage, right? Remember, infarction means tissue death because of oxygen deprivation. So this is the heart muscle, myocardia, that is dying because blood's not getting to it anymore. The blood and the oxygen contained within it is not being delivered to those tissues, and then they start dying. If we're talking about a small artery, right, that feeds a relatively small portion of myocardial tissue, then you're going to be talking about a small heart attack that you might not even actually be able to detect in some cases. If it's one of the large coronary arteries, right, that becomes entirely occluded, becomes entirely blocked, or 70% plus becoming blocked, is really enough to starve the tissues downstream of oxygen. Now we start talking about a big heart attack. That is enough that it's going to cause enough tissue death that the heart's function is going to be pretty substantially impaired from there on out. So when these tissues die, they can't actually depolarize in the way that the heart tissue is supposed to. Remember, myocardial tissue is acting as syncytium. It's acting as one unit. So because of all of the intracellular connections, when one muscle cell squeezes, the other muscle cell next to it squeezes pretty rapidly after that. That's the way things are supposed to work. But if this tissue becomes replaced with kind of fibrotic material because of a big giant infarction event, well, now all of a sudden, that's not going to be able to relay these electrochemical messages as effectively. So we can kind of categorize a myocardial infarction depending on how much it alters the depolarization wave within the myocardial every time we go through a heartbeat. So we could be describing them as STEMI or NSTEMI. So STEMI is just, it's affecting the ST portion of that myocardial wave. And NSTEMI is you don't really see that big of a change to the electrochemical wave. This is entirely dependent on how much muscle tissue is actually damaged and destroyed by this infarction event, right? So, hey, this is that QRS, right? The QRS region. Well, if we are talking about a STEMI event, we're talking about a pretty big swing in how this electrochemical depolarization wave moves around the heart, and you have a elevation of that ST portion of that echocardiogram. So electrocardiogram, sorry. So STEMI is a sign of more damage. In-STEMI is telling you that, hey, there's maybe some damage going on there, but there's not that significant. It's not that big of a deal because we're not really altering the EKG wave that much. This is just what that would actually look like in the real world, right? An example of an in-STEMI versus STEMI heart attack being, hey, a large chunk, but there's still contractile tissue, right? So this area is still going to contract. It's still going to squeeze like a normal heart would. This would obviously be the left ventricle because it's the one that's entirely surrounded by big, giant, beefy tissue, and this is obviously the right ventricle. Something like a full thickness myocardial infarction that causes STEMI elevation, right? So ST elevation is a sign that this is just going to be scar tissue. Everything within this is really just going to be collagen. And that's not going to squeeze anymore. That's not going to be able to effectively move blood compared to even a in-STEMI heart or a normal heart. When heart tissue dies, heart tissue is going to explode. It's going to necrose. When that occurs, that's not going to be able to, when we stop delivering oxygen to tissues, now all of the contents of those cells are going to bust out and jump into circulation. One big indicator that we use for the severity of a myocardial infarction is something called cardiac troponin. Troponin is a protein that's going to aid in the kind of muscles squeezing with each other under normal function. And we're not normally supposed to see cardiac troponin in any large quantities within the bloodstream. It's supposed to be within our cardiac muscle cells, our myocardia. Well, when that myocardial explodes, now it dumps all of this cardiac troponin, and it's a sign that we can actually take a blood sample and look for the concentration of cardiac troponin to tell us how bad that heart attack actually was. Right? To see what that actually looks like, we're going to be clearing this troponin away, right? So it's going to decline over time. But something like a mild heart attack, with these small heart attacks, aren't going to cause that much cell death, so they're not going to cause that much cardiac troponin to be released. Something like a major myocardial effect, so like a giant heart attack, is going to cause something more along these lines, where we have a bunch of cardiac troponin being dumped out because a bunch of myocardia has died, right? So that tells us that in this red line, the heart is a lot weaker compared to this orange version, right? There's more muscle death, so there's a greater loss of function after this myocardial infarction. If we start to be concerned about a heart attack, timing is, just like when we're talking about strokes, timing is incredibly important. If we start to be concerned that a heart attack is occurring, if we come in and clear that blockage, remember the infarction is caused by an occlusion of a vessel, and then all of the tissue that's downstream from that blood is dying because of a lack of oxygen. If we clear that blockage, we blow that clot up within a relatively short window, well, that tissue is not actually infarcted, it's just ischemic. It's a little stressed because we didn't give it oxygen, but it's not dying because of it. So an example of something that would help us are when you hear about people that are like taking aspirin, low doses of aspirin all the time. Aspirin breaks up clots, it acts as a thrombolytic. So by constantly being on low levels of aspirin, it prevents these clots from building up to the point that it's going to cause a big giant myocardial infarction. Maybe we could be talking about small clots, but nothing that's actually going to kill that person, or at least hopefully. How do we deal with this in people that have large occlusions? Well, we're going to give them an angiogram. The angiogram we're going to see here in a moment is going to actually identify where that blockage is, and then we can actually insert a balloon and stent open that vessel. So when we stent open that vessel, it's going to prevent it from actually being occluded and being blocked. This is why we care about thrombolytic medications, right? Remember, fibrinogen is activated to become fibrin. Fibrin forms that mesh that blocks and acts as a kind of a glue that keeps everything stuck together. Plasmin is a thing that actually cuts and breaks up fibrin mesh. Thrombolytic medications are going to increase by telling more plasminogen, hey, we need to convert you to plasmin faster, right? So these thrombolytics are clot busters, thrombolysis, right? Lysis is a split, thrombus is a clot itself, right? So this is going to increase the concentration to plasmin and hopefully increase how much we break up this fibrin mesh. When we're doing an angiogram, we're going to insert these dyes inside the bloodstream that will get picked up on x-ray and that are very distinct from any other tissues around the body, so we can very clearly see where that blood is flowing to within even relatively small arteries. So if this is a sign that, hey, it's pretty much the same color throughout this whole thing, versus, hey, there's blood flowing here, but then all of a sudden it has a pretty significant color change. Well, that's a sign that there's a drop in the blood delivery. All of this tissue is not getting as much blood because of the occlusion that's happening at that particular site. That angiogram tells us, hey, this is exactly where we need to deal with that clot. So when we are doing ballooning and stenting on individuals, this is something that could be a full clot that we need to go in and address, or this could be kind of a preventative measure. So we're going in and stenting because we're kind of concerned that this area is starting to become so occluded because of that buildup of fats and calcium that it's actually blocking the blood flow. So if we just put a balloon in it ahead of time, the hope is that it's not going to allow a clot to form to actually cause the damage. So we can kind of do this ahead of time as a prophylactic as well. You've also probably heard the idea of like a heart bypass surgery, and what effectively that is we are taking blood and routing it around an area that we think is actually damaged, or we think that might be occluded relatively soon. So quadruple, single bypass, right? But what we're talking about is how many of these extra inserted vessels we're applying to an individual, right? So the more we are talking about, the more risky it becomes, because there's probably a lot of areas that are heavily occluded in someone with like a quadruple bypass. A myocardial infarction kills you because it drops off your blood output, right? You don't have any blood leaving your heart, your cardiac output declines. All of the rest of the tissues, brain, liver, kidneys, right, are not receiving enough oxygen. That ends up what ends up actually killing you, right? So small myocardial infarctions are not going to substantially alter heart function, but if we start talking about larger chunks of heart dying, well, now that heart is not going to be as effective at pumping, and it's going to eventually fail. This is one of the reasons why somebody that has a heart attack is more likely to have a second and third and fourth heart attack, because the heart is getting weaker and weaker, making it more likely for an additional occlusion to occur. When we're talking about shock, remember we drew the shock cycle previously, and we're going to redraw it here in a second. I just want to introduce the idea of the fact that, hey, it's not just septic shock that matters. There's also a lot of other ways that we could be talking about how an individual becomes shocked. So when we're talking about shock, just to refresh our memory of what we're actually really talking about, we'd previously only talked about septic shock, where an individual has some sort of inflammation and then that inflammation leads to an increase in the blood vessel diameter, right? So blood vessel vasodilation. That vasodilation eventually leads to a drop in blood pressure, so we have hypotension occurring. Hypotension is going to lead to, hey, if I don't have as much pressure pushing that blood ahead of time, we're going to have poor perfusion. As perfusion drops off, we're going to have poor tissue oxygenation. There's not going to be as much blood flowing to that tissue, so obviously there's not as much oxygen flowing to that tissue, that tissue starts to become ischemic. We have tissue ischemia occurring. If this persists, we could have something like tissue infarctions. If that tissue actually dies because of an absence of oxygen, because it's either they've been starved long enough, or even if a short-term ischemia happens for a really long time, it could lead to an infarction. And that infarction is going to cause those cells to die. Well, then now I have a bunch of inflammatory release of molecules that further this shock cycle, right? This tissue cell in death, we could also kind of include the heart here, where if we have an infarction occurring within the heart, right now we have poor cardiac output. CO is cardiac output. Poor cardiac output combined with vasodilation means hypotension, right? My heart's not pumping that much, so I'm going to start causing failure. Some examples of the way that this actually happened. We previously talked about septic shock, right? And septic shock, our kind of entry point is in that inflammatory event. Something like hypovolemic shock. Volemic as in volume. So we lose a bunch of blood. We lose 30-40% of our blood. That's going to throw us into a hypertensive event. We've lost enough blood that we don't have as much to fill up the chambers that we do have. We could be talking about something like anaphylactic shock. Well, there's nothing really wrong with my blood delivery, but if I have I'm going to go into anaphylaxis because of some allergic reaction to some bee sting or peanuts or whatnot, the blood, even if it's flowing, is not going to have good perfusion. It's not going to have that much oxygen within that because I'm delivering poorly oxygenated blood because the air is not being delivered down to those alveoli. So now I'm talking about anaphylactic shock. And the last one that kind of ties this all together is something called cardiogenic. So cardiogenic shock is going to be a heart attack, right? Something causes damage to the heart that can lead to hypertension because our cardiac output declines. Then we have poor perfusion, ischemia, and we start this shock cycle because of the heart and the initial heart attack. These are all just ways that we can enter into this shock cycle, right? This is a cyclical disorder. It's going to get worse before it gets better, right? This is why we need to intervene and avoid shock in the first place, right? As this is happening, this becomes a pretty high mortality event. We want to try and avoid it because more heart tissue that dies means more poor perfusion, which means more heart tissue that dies, right? This is why more heart attacks come in series with each other. You're more likely to have a second heart attack than you are to have the first initial one. The last thing that I want to talk about are heart rhythms. And when we're talking about cardiac heart rhythm, you have to understand a little bit about how this electrical wave is moving around the heart itself. Initially, a heartbeat is being caused by the sinoatrial node. The sinoatrial node is this little thing that is kind of hanging out at the top of that right atria. This sinoatrial node is something that's going to be persistently depolarizing. So unlike a nerve or other cardiac tissue, it doesn't need any extraneous input to depolarize. As soon as that sinoatrial node is ready to go again, it will fire, right? It will perpetually happen almost like clockwork, right? This is what's giving our heart its kind of repetitive pattern is the sinoatrial node. So the sinoatrial node fires, and then the atria, this electrical stimulation moves throughout the atria squeeze, and then that signal is being collected by this node here, this AV node. This AV node is responsible for the fact that we actually don't get a atria squeezing and then immediately the ventricle squeeze. this AV node takes a pause and then sends the signal on down through the bundles of His into those ventricles themselves. So when we're talking about this, this is how this is supposed to go. We can kind of map this and see on an EKG a P wave, QRS, and T waves. Well, those correspond to the squeezing and depolarization that's happening around the heart itself, right? That P wave being a little bit smaller than the R wave, the QRS complex, because there's not that much muscle in the atria. There's a lot of big, beefy muscle in the ventricles. So when those depolarize, you get these big, giant swings. And the T wave is basically a wave that expands those ventricles back out. It pops them back open to accept more blood on the beginning of the initialization of the next wave. If we're talking about kind of these abnormal heart rhythms, if we start to have problems in the sinoatrial node, be it electrical signals coming from the brain, drug-induced versions, catecholamines like epinephrine-induced changes, or if there's some kind of structural damage to the sinoatrial node, like a heart attack that's occurred in the area, or genetic conditions that you're born with, right, that sinoatrial node is not depolarizing at the correct way, so you could be tachycardic or bradycardic, right? This is not the only way this can happen, but if you have problems with sinoatrial node, it tends to be a pretty big deal. As the sinoatrial node fires and sends that signal out to the atria, that signal that is causing the atria to squeeze is actually being collected at that atrioventricular node. That is easy to remember because AV node, it's the thing that connects the atrial signal and the ventricular signal. So when we're talking about heart blocks, we're really talking about a problem at that atrioventricular node, at that AV node. So heart blocks can also be called AV blocks when we're talking about that. And we can describe them in terms of the severity of the block that's occurring. First, second, and third heart blocks. The third heart block is a really big deal. First block is a little bit less of one, right? This is the way that things are supposed to happen, right? AV node is receiving a signal from the sinoatrial node. It's waiting a second and sending that out to the ventricles themselves. It's sending that out to the ventricles themselves and pausing. We really want that pause because we want the atria to squeeze and to give that blood that's in the atria enough time to flow into the ventricles themselves. Then the ventricles can squeeze and send that signal out to send that blood out to the body. First degrees are easy. First degree heart blocks there's too long of a time between the initialization of that QRS complex when the ventricles are squeezing and the P wave. Most people that have a first degree heart block, right, something's gone wrong and there's too big of a delay inside that AV node. Most people that have this don't actually know that they have a first degree heart block. Unless you've had an EKG done, you wouldn't actually really know in most cases. There's no significant alteration unless we're talking about a really long heart block, right? We find these when we're seeing, hey, the P wave is way too far away from the R wave, right? A consistent PR interval of over 200 milliseconds tells us that something's gone wrong. This becomes a problem because it's not pushing that much blood out of the heart, right? This is an inefficient squeeze. We would like, if we have this P wave to fire, right, that squeezes all the blood from the atria, all of that blood moves into the atria, and because we're just waiting too long, that blood is just kind of like sitting around and not doing anything. It's kind of inefficient. So a better way would be to fire as soon as that ventricle is filled. Second degree heart blocks actually have two types, and the types are unfortunately complicated. We describe them as either a Mobitz 1 or 2 or a Mobitz 1/Winkelbach. So Winkelbach is the same thing as a Mobitz type 1. So if you ever see Winkelbach and Mobitz type 2, those are talking about two different mechanisms. I'm going to try and use Winkelbach because it's the more common discussion when we're talking about this heart block. A second degree heart block that's a Winkelbach is, hey, we have a normal P to R interval, and then that PR interval slowly slips, right? It is getting longer and longer and longer until eventually, like what you're seeing on this third beat, is we have our P wave, but then it's so long that it actually doesn't mobilize a QRS complex. So this is the idea of skipping a beat, right? Your heart skips a beat in a Winky-Bach heart arrhythmia. A Mobitz 2 is a persistent PR interval, right? It is always going to be over a 200 milliseconds. It's like a type 1 heart block, but eventually you get a drop, right? So these are not going to be slipping and getting longer and longer and longer and then dropping. That's going to be a Winky-Bach. Mobitz 2 is a perpetually long PR interval and then eventually dropping a beat. You can kind of use the nursery rhyme, longer, longer, longer drop. That is a Winky-Bach. That tells you what a Winky-Bach is versus a Mobitz type 1. And in finding this, I found, in looking for videos to share with folks, I found this abomination, and I'm going to watch 30 seconds because I can't physically bear to see it again. This is what happens when you're too bored on wards. You come up with these ideas and think it's a good idea to make this. And you get the point. It's done now. Okay. I hope I get banned on YouTube for showing that. That's really rough. But if that helps you remember, awesome. So first degree heart block, long PR interval. Second degree heart block, Mobitz type 1 / Winky-Bach, it slowly gets longer. Mobitz type 2, perpetually long PR interval, and eventually just randomly dropping a QRS beat, so the ventricles never squeeze. Third degree is the worst kind. And the third degree is the worst kind because what you're seeing in a third degree heart block is the atrias have a consistent beat, right? Atria squeeze, 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 and the ventricles also have a persistent squeeze, right? They're not losing beats or they're not lengthening the QQ the intervals. So the ventricles are squeezing, squeezing, squeezing. Why is that a problem? Well, what you're seeing here is you're seeing the distance between the R here on the top is always the same. Right? We're not talking about a change in any kind of intervals. We're not dropping beats at all. But in a third degree heart block, this becomes a really big problem because when we are squeezing our atria, we're supposed to squeeze the atria, pause a brief period of time for that blood to flow into the ventricle, and then the ventricles go. Occasionally in third degree heart blocks, some heart cycles are going to work like that and work like they're supposed to. But also some of them could be having the atria and the ventricle simultaneously squeezing. Well, if you're the atria, you're always going to be overwhelmed. The ventricles are way bigger and beefier muscle, so it's going to always squeeze that blood and prevent the atria from pushing the blood into the ventricle. It's almost like that beat is not really going to do anything at that point, right? Because there's no blood in the ventricle itself. If they're both relaxing at the same time, it's the same sort of situation where that blood is stagnant in the heart. It is not effectively pumping. Some last discussion that I have about heart arrhythmias are fibrillations and in both the atria and the ventricular system. Fibrillate is the description of how a butterfly flies. So if you ever see a butterfly flittering and then pausing and flittering, right? That flittering motion is fibrillating. If we're talking about a signal that in the atria, right, the sinoatrial node fires, it sends that electrical signal out to the heart. But if you have portions of the heart that don't actually ever depolarize, but then continue cycling of this electrical signal within the portion of the heart, well, that's going to cause perpetually squeezing of this portion. Atrial fibrillation is the version of his that you're seeing with this red line that's showing this kind of sawtooth pattern where you have big deep cuts, which are squeezes of the ventricles, right? These R's are squeezing. But the problem is the atria is not really effectively pushing blood because the atria is kind of squeezing a very small amount and then refilling before it, and then squeezing before it actually really has time to refill. That's a problem, but it's not the biggest problem. The bigger problem is when we start having ventricular defibrillation, right? Or ventricular fibrillation. When we have the ventricles fibrillating, that's the stuff that's actually pushing the blood out to the body or the lungs. And if I'm firing the ventricles before they've actually had time to fill with blood, that's obviously going to be an inefficient squeeze. If I'm firing it as it's like has just emptied again, right, and then I fire it again, well, I haven't done anything. I've wasted my energy making my heart do more work than it actually needs to. I talk about tachycardia and fibrillation at the same time because oftentimes when we're talking about patients, you're going to have a regular sinus rhythm, SR, so a regular atrial squeeze, ventricle squeeze, atrial squeeze, ventricle squeeze. And then if there's something, either a genetic problem or damage from a previous heart attack or damage in the brain that's sending signals inappropriately to the heart, we have that heart starting to kind of lose its normal beat and it starts beating too rapidly. It's kind of causing these ventricular tachycardia. And then eventually it degrades to the point that now there's just not anything that looks like any regulative beat there at all. This is just a fibrillation, right? We degenerate into fibrillation, which is something that is a really, really big problem, right? Because we're not pushing blood out of the heart. This is when defibrillators come in, right? If the heartbeat is so inappropriate that we're squeezing when we're supposed to be relaxing, we need to reset this whole system. So the way that we do this is we send an electrical shock over the entirety of the heart. It causes everything that can depolarize it to depolarize, and then now it's going to restart this system. It's rebooting up how the electrical pathways of the heart. I talk about this because it's something we obviously do in surgical rooms, in patients that are defibrillating. In reality, defibrillation is under a 20% success rate, right? So out of every 100 patients that you get on top of and start trying to get their heart started back up and then put the paddles on them, about 80 of them are going to die at that moment. So that's something that I want to describe because you hear stories of nurses and doctors going out and expecting to be able to pull these patients back every time, and that's definitely how it works on, I'm guessing, Grey's Anatomy. I haven't actually seen it since 2009, so I'm guessing but I'm guessing it's probably the same. Somebody defibrillates, you stick the paddles on them, and they come back, and that's not really actually how it terribly works anymore. Not anymore. It's never really worked like that. One thing that we can do to try and address these kind of arrhythmias, these inappropriate rhythms, these things firing when they shouldn't be, is putting a pacemaker in. And a pacemaker is an example of a surgery that, yes, it's a pretty serious surgery, but we're not actually opening up the chest. We're not actually opening up the heart, because most of the time we'll end up just putting this pacemaker unit underneath the skin and then threading a electrical lead into the heart itself. And what this is doing is it's enabling us to send this electrical pulse without actually having to kind of faff around with the opening of the heart itself, cracking the sternum, which could be a really big deal, obviously. We're trying to avoid that. We don't place the pacemaker close to the heart for two reasons, right? The fact that we don't want to do open heart surgery if we don't have to, and the fact that we have this electrical signal generating thing could mess up the normal electrical signal of the heart, right? So we don't want any kind of interference coming from the pacemaker. This is an example of an EKG that you'd see of a patient that has a pacemaker. This big giant, where am I? This big giant spike that you're seeing ahead of the normal P wave, that is the pacemaker signal that is trying to set off and initiate a sinoatrial node signal in that P wave initially. So that's a clear sign that someone has a pacemaker inside their heart firing at the moment. That's all we're going to do for this, and then I'm gonna send a video in a moment. We're going to re-record this and start in our next bit on the pulmonary system.